All right, well, if everybody can grab a seat, we'll go ahead and get started. And I guess we have a lot of people joining us online tonight as well. So on behalf of my co-president, Barbara Schillinkrodt, and myself, welcome to the 1066th meeting of the Boston Society of Neurology, Neurosurgery, and Psychiatry. So for those of us that have been meeting with us since 1880, thank you for your commitment. Good to see you all again. It's my honor tonight to introduce Dr. Emery Brown, MD, Ph.D. He's the Edward Hood Taplin Professor of Medical Engineering and Computational Neuroscience at MIT. He's also the Warren M. Zapol Professor of Anesthesia at Harvard Medical School and an anesthesiologist at Mass General Hospital. He received his BA in Applied Mathematics from Harvard College, his MA and PhD in Statistics from Harvard University, and his MD from Harvard Medical School. Professor Brown completed his internship in internal medicine here at Brigham and Women's Hospital and his anesthesiology residency across town over at MGH. Professor Brown is an anesthesiologist statistician whose research is defining the neuroscience of how anesthetics produce the states of general anesthesia. He also develops statistical methods for neuroscience data analysis. Professor Brown is a fellow of IEEE, the American Association for the Advancement of Science, the American Academy of Arts and Sciences, and the National Academy of Inventors. He's a member of the National Academy of Medicine, National Academy of Sciences, and the National Academy of Engineering. He's also received so many awards that it would take the rest of this evening to read them off. And so just assume that if there is a award out there relevant to neuroscience and anesthesia, Dr. Brown has received it. It's my honor tonight to introduce Dr. Emery Brown, and very much looking forward to your lecture. Thank you for joining us.
Great. Mike, thanks for having me. Thanks for coming, and thanks to those of you who are online. So what I want to talk about is general anesthesia. I call it neuromodulation, altered states of arousal. And let's see, click here. Before I begin, I just want to offer these disclosures: financial support from NIH, from my Department of Anesthesia at Mass General Hospital, my institutes at MIT, and also these potential financial interests that may come out of the work that we're working on here. These are my colleagues that I've been doing this work with for a number of years: Patrick Purdon, who's at MGH, Nancy Gopel, mathematician at Boston University. Shuna Kate, can you come a little closer? I'll move over this way a little bit. Shuna Keiju, who's our new chair of anesthesia at Mass General Hospital, has been there 3 years now. Ken Salt, anesthesiologist. Laura Lewis, who's one of my PhD students, she's now in the faculty at MIT. Earl Miller, my colleague at MIT. Miriam Shinichi, who is one of my former PhD students, now at USC. Shenung Ching, former postdoc, who's now out at WashU. Ahmad Eskenar, neurosurgeon, who, as you all know, was at MGH and now is down at Einstein. Jake Donahue, former PhD student. Suresh Chakrabarty, former postdoc, and Sid Cash, neurologist, I'm sure most of you know. So this is the outline I'm going to follow. I'm going to talk about anesthesia-induced slow oscillations. Then I'll tell you some factoids about anesthesia after we do that. Then I want to talk about the principle of multimodal general anesthesia, closed-loop control, and then reanimation, turning the brain back on. But let me start with a definition. So what is general anesthesia? So it's a drug-induced reversible state that consists of antinociception, unconsciousness, amnesia, akinesia, and physiological stability. If you take those first four things there without the reversible, they're synonymous with death, okay? And on that list of things that's not cool, that's really not cool, all right? So the reversibility is actually a very important part of this. I starred the antinociception because when I first wrote this definition back in 2010 in our New England Journal paper with Nico Schiff and Ralph Leidig, I wasn't that precise. I actually said analgesia, but it really has to be antinociception because it's what's happening when the person is unconscious, not when they're conscious. So just to try to, and this is not trivial because one of the reasons we've made very little progress in anesthesiology is we haven't agreed on a definition of what it is we're doing. You hear people saying the depth of anesthesia. Never say that word again. You'll live long and prosper, all right? All right? But these issues, these definitional issues have gotten in the way of us really understanding what we're doing. And as I was just saying to Mike earlier, anesthesiologists love to say, well, we don't know how it works, right? I mean, it's a mystery, right? It's like you've got to be in the club. If you're in the club, you know how to give it, and you know you can. But if you don't know how it works, you can't make any improvements in it. So I just want to show you how it works is not a mystery. We don't have all the answers on how it works. I'm just going to show you at least one or two major ideas. I want to start with anesthesia-induced low delta oscillations. And for this, I want to go back to sort of a historical markup. So as you all know better than I do, Frederick Brigham did a series of experiments in cats back in 1935. In the first set of experiments, he transected sort of the brainstem from the spinal cord at the level of A. And he looked at the cats, he measured their EEG, and it looked like this. It looked like an awake appearing EEG. And he called it the encephale isolé, meaning the isolated encephalon, all right? Then he did a second set of experiments in the cats, another set of cats, where he transected up here, almost up here at B, where you're getting pretty much most of the brainstem and then sort of the cerebrum separated from it. And he called this the cerveau isolé. Cerveau, not so much in the sense of cerveau meaning brain in French, but cerveau meaning cerebrum, isolated cerebrum. And what he saw were these large slow oscillations. So that was one of the first set of experiments that told us there's something down here in this part of the brain, down here, sitting in here, that has to do with what we now call arousal, all right? And one of the things I'm going to show you, and I'm going to call this Brigham principle, right? And one of the things that we know now with anesthetics, all anesthetics have targets in the brainstem. So they're all going to produce slow oscillations, but by different mechanisms. That's the main point. All right, so let me just show you this right from the start. So we have EEG and our LRs. We can put 4 leads on every patient that we take care of. And this is a woman I took care of. You can see this is more than 10 years old, almost 10 years old now. It's 2013. She's 60 years old. She weighs about 80 kilograms. She's going to have a thyroid surgery. And I'm just going to give her a bolus dose of propofol, 150 milligrams. And this isn't edited. I'm just going to play it for you, show you the video, show you what happens. So, you're going to see this get very noisy all of a sudden. Because as you know, if you inject propofol in a small vein, like on the back of my hand, it burns like crazy. That's what's happening now. She's doing this. She's tensing up, all right? That's actually going to be good from a pedagogical standpoint, because at the point where the anesthesia takes over, you're going to see it very precisely. So watch right here. Right now, beta oscillations, slow oscillations, affecting her brainstem, even deeper slow oscillations. So she stopped responding right then. She became unconscious. And now you're going to see them become slow, sort of flat, and then burst. She's in burst suppression, just like that, right? She's completely unconscious, all right? So what did I just show you? I'm going to move this. This floating control keeps popping back in the way here. You can't see it, but I certainly can. There we go. All right, so she went from the awake state, so about 5 microvolts or so, all right? And look what happens as she went down to these states of, first in the state of sedation, when I said take a look at C. So you see those are beta oscillations. Like if I wanted to anesthetize her so that she could have a colonoscopy, I would titrate the propofol and hold her in that state there. And she might interact with me, be able to respond, but maybe have no memory of what was transpiring. And then look down here, we'll come back to D. She went to E. You saw the large slow oscillations, right? And so again, if we apply Brigham's principle, we can think of that's probably a brainstem effect. Not just a brainstem effect, it's affecting the thalamus, it's affecting the cortex. It has to, because the inhibitory interneurons are basically everywhere. And propofol is a GABAergic drug. It works by enhancing GABAergic mediated inhibition. And then we saw her go into burst suppression, which you all know, obviously a state of profound brain inactivation. Probably due to a good extent to metabolic actions of the anesthetics, likely GABAergic anesthetics in particular, likely on the mitochondria. And between the bursts, she's isoelectric. The point I want to make, I want you to look at the size of the oscillations. She starts off at 5 microvolts, and they start to get larger and larger, larger and more structured, all right? So you can already start to see the brain is becoming quite inflexible, quite structured. It's going to be very hard to transmit information. I'm hand waving now, I'm not making this precise. But you can start to understand by looking at the oscillations why someone would be unconscious. But even more importantly, if I take a woman, like I said, she was about 60 years of age, I keep her in a state like E, or from time to time in F, for 3 or 4 hours, her brain is not supposed to just pop right back and be healthy. It's too much to expect. So we can already just start to see, looking at what the oscillations are doing, why we would have brain dysfunction after anesthesia. I have to throw this in though. So what I just said was sort of said years ago. If you haven't read this paper, you've got to read it. 1937, Gibbs, and Lennox. They actually won the Lasker Prize for their work. They were people who really popularized the use of the EEG clinically. And if you read what they said right here, in a surgical, so they're showing patterns which look just like the ones I just showed you, right? In ether anesthesia, when a surgical level is reached, the slow waves have a frequency of about 1 hertz, basically. Superimposed on these are small, faster waves with a frequency of about 10 to 20 hertz. We actually saw those. And so that the slow waves have this acrinated appearance. A practical application of this observation is we might use electroencephalogram as a measure of depth of anesthesia during surgical operation. The anesthetist and surgeon could have before them a tape or screen, a continuous record of electrical activity of both the heart and the brain. That was said in 1937. Right now, in the operating rooms, at best, 28% of anesthesiologists use the EEG. They don't monitor the brain. Everything is just done empirically and by convention. As amazing as that might sound, but that's the reality of it. And it comes from, it's a cultural practice. Anesthesiology is believed to be a subdiscipline of pharmacology, not clinical neuroscience. So one of the things that I've been trying to do is promote the more use of neuroscience and neuroscience thinking in anesthesiology. But, I mean, this is 1937. So one quick little refresher on signal processing. So if I had a signal like this, a raw signal, and I knew which frequencies I wanted to pull out, I could have an engineering colleague of mine build me a filter, and I could say, hey, pull out the 10 hertz oscillation and pull out the slow oscillation. They could do that for me. But the oscillations are going to be moving all around during the anesthesia, so what we need to do is have a way of looking at the oscillations across a wide range of frequencies. So what you do is you compute what's called the spectrogram, or the spectrum, first of all. So you take the swatch of data, and you figure out all the frequencies, you figure out the amplitudes of all the frequencies that are in this one signal back over here. So look, there's a low frequency component somewhere around about 2 hertz or so. There's something about 4. There's a lot about 10 to 12 hertz. And after 15 hertz, there isn't very much. And effectively, you can think of, this can actually be done by just fitting sine waves to this and taking the square amplitude of the sine waves, essentially. That's approximately the same thing, all right? But, so that's just one 10-second window of data. So what we're going to do is we're going to move that along over time. And if you do that, if the black line here is this guy here, then as you do this over time, you're going to get a mountain range here, a valley, a mountain range there, and then here's the ocean over there, all right? The same sort of thing. You're just repeating that over time, and that's a spectrogram. So when it's over time, we call it a spectrogram. If it's just a single swatch of data, it's a spectrum, all right? And we don't look at it in this 3-dimensional view. We look at it usually from on the monitor in a 2-dimensional view. So you're looking, it's like you're in a helicopter perspective on it, like you're flying over it. So if you look right here, this is the 10 hertz oscillation, which we saw in this signal here. Over time, here's the slow oscillation going from about 0.1 to about 4 hertz. So this is a classic signature of propofol or any GABAergic anesthetic. So the ethers, pentobarbital, etomidate, all of them have this basically the same structure, all right? So this is what it looks like in the operating room. And this is a young woman I took care of a few years ago. She was having a short procedure. So how do we do this? We start the propofol here, we run an infusion, and you see the oscillations come on like this. Here's the 10 hertz oscillation, here's the slow delta oscillation. And actually, just to be sure of what I'm talking about here, let me just go back. I'm just going to go back a few slides here. What I'm showing you is basically this pattern here in D over time. See, there's a low frequency oscillation, a slow oscillation, and there's a higher frequency one there. That's the one that the Gibbs and Linux were describing, all right? So it's even here today, all right? So that's what I'm showing you here in this picture, all right? So how does this come about? Well, GABAergic interneurons are everywhere. So they're certainly in the cortex here. They're certainly around the thalamus and the TRN, and they're all throughout the brainstem. So all those places are targets. But I just want to point out one probably very important target, at least we're talking about the slow oscillation. Here's the preoptic area of the hypothalamus. This is in an area that Cliff Saper and his group has done a lot of work on describing, and so the anatomy of it. And Cliff has pointed out that you've got GABAergic and galinergic projections coming out of here that are kind of like my fingers. And this is my wrist here, that's the center. And they hit all the arousal centers. So propofol comes in through here, up the basilar artery, and goes, wow, inhibitory sites. It just goes crazy, pung, 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 pung. Just takes them out. That's how you get the slow, that's one way, as one component of the slow oscillations that we just saw right there. And clearly, as you hyperpolarize the cortex, either directly or indirectly through the TRN, that sort of adds to it. So this is one of the mechanisms through which we're getting essentially these slow oscillations from propofol. But let me show you some of the best human data that I have. So this is from Laura Lewis's Ph.D. thesis. It's now sort of 10 years old. So like just here at the Brigham as well as at MGH, we have patients who come for epilepsy surgery. They get grids of strips implanted. Now it's more stereo EEG, but you know, this is from, again, a little over 10 years ago, work we did with Sid Cash. So we record the field potentials. We can record them at 3 different sites on the cortex. So the patients stay in-house for 5 to 7 days. They seize off the medications. You bring them back to the operating room. You remove the electrodes in the exception operation. You then do the resection, all right? So here's a patient when he was conscious, he was conscious. This is what his spikes are doing. And over here, you can see what his field potentials are doing. So the colors correspond to the sites here across the medial temporal lobe. Now look what happens here when the person's unconscious. You can only spike now. Only spike now. Spiking roughly every 2 seconds, 2.5 seconds. All right, now, I can't tell you how much the spike rate has to drop for someone to be unconscious, but I would submit to you if every neuron around the cortex can only spike sort of every 2 seconds or 2.5 seconds, it's going to be very hard to transmit information among various parts of the brain, all right? So certainly the slow oscillation, seeing it on the EEG will let you know that someone's unconscious. And this is why it's important, as I said, my colleagues are not doing this. This is not standard practice of using the EEG this way. And let me just show you some more recent data which we've been able to put together thanks to Earl Miller. As you know, Earl Miller is one of the world's most prominent non-human primate neurophysiologists. We did the same experiments in non-human primates now, except what we can do is we can record from 4 areas simultaneously. So this is 8A, so the frontal eye fields, prefrontal cortex, posterior parietal cortex, superior temporal gyrus. So here are the field potentials when the animal's awake. And down here, what you see is the spiking activity, right? And now, same thing, give propofol. The animal becomes unconscious. Here are the large, slow oscillations like I was showing you before. Now look at the spiking activity. So just to put this in perspective, the spike rate here is there's about 10 to 12 spikes per second. Over here, it's a half to 1 spike per second. And you can see the large gaps in the spiking. It's 1 to 1/2 spikes per second when they're spiking, all right? So again, I can't tell you how much the rate has to drop for someone, for the animal to be unconscious, but I would submit to you it's going to be very difficult for this brain to transmit information. Right? And I want to contrast that now. I'll show you the same thing, just a different way. This is analysis done by Josefina Correa, who's one of my Ph.D. students. So here's the propofol experiment again. So the spike rates, as I said, about 10 to 12 spikes per second. You start the propofol infusion, the animal loses consciousness. Here you see the spike rate going down. And we turn the propofol off, and gradually the spike rate comes back up, and the animal becomes responsive here. And so here's the 4 regions that it's all happening simultaneously. Right, so this is going from 10 spikes per second, 10 to 12 spikes per second, down to 1/2 to 1 spike per second. So I purposely asked Josefina to contrast this with ketamine. So we did a very similar experiment with ketamine. Give a bolus of ketamine, the animal behaviorally becomes unresponsive. Look at the spike rate. The spike rates are roughly the same as when the animal's awake. There's much more variability in it. And this animal here is unconscious too, just like this one. So they're, not surprisingly to you all, certainly the neurologist, as you think about the brain, you can have strokes it could be into the cortex, it could be in the thalamus, it could be in the brainstem. They would render you unconscious. So there are many ways to become unconscious, all right? And let me just say a little bit more about contrasting ketamine with propofol. So this is what happens when you give low-dose ketamine. When you give low-dose ketamine, you actually get a high-frequency oscillation somewhere in the gamma range, about 20, 30 spikes per second, 20, 30 cycles per second, all right? And that's sort of what you're seeing here. When you give enough ketamine so you can actually anesthetize someone, and remember, just a little parenthetical insert here, ketamine is considered by the World Health Organization an essential drug. So if you had to go to some remote area to give medical care and you could only take one drug with you for anesthesia purposes, you'd probably take ketamine. Because not only does it render you unconscious, but it's also a very potent analgesic. Propofol is not an analgesic, right? It's a hypnotic, it'll make you unconscious, but there's no analgesia associated with it. So you would take ketamine. But then what happens is when you give a dose which is sufficient so someone can be unconscious, you get this really cool dynamic. Look at that, it goes fast and then slow, then fast. You can see it here in the spectrum, see? There are the high frequencies, then it goes slow. Fast, then slow. And so Suresh Chakrabarty, my postdoc, and Indy Garwood is one of the HST students. This is her PhD, a good part of her PhD thesis. So when we start thinking about Bremé's principle, and we see these slow oscillations, we say, well, that suggests that there should be some targets in the brainstem where ketamine is working. And as we know, one of the primary targets of ketamine is NMDA receptors, all right? So it's blocking glutamate. And there are a number of sites where this could occur. I just put down to the parabrachial nucleus, projecting central thalamus in the basal forebrain, also the medial pontine reticular formation, projecting to the same locations. So those are the potential sites where the ketamine could be working. So one of the things that Indy did was characterize this in a little more detail. So this is actually, what I failed to mention is, this is human data here, right here. Now this is the experiment done in the non-human primate, right? So we'll take a segment of this data here, this part right here, and blow it up over here. So now you can see it. See, there's the fast, slow, fast, slow. And it turns out you just don't go fast, slow, fast, slow, fast, slow. You start off, let's say you're going slow, we'll start here. You get a little faster, then all the way to fast. So there are about 3 or 4 states you go to as you make the transition from being slow to fast. It's not just a switch flipping back and forth. And so this dynamic, and this is entirely different from what I just showed you with propofol, an entirely different sort of, and this is one thing we're working on with Nancy Gopel, come with a sort of mathematical description of this. And if you look over here, you take those 4 brain regions. So right here, almost 50% of the time, all 4 regions are completely synchronized. About 70% of the time, the posterior regions, so the posterior parietal cortex, superior temporal gyrus are synchronized. About more than 80% of the time, the frontal areas are synchronized. So in other words, again, what you have is highly structured oscillations, which are going to make it very difficult to transmit information between various parts of the brain. So this is one of the mechanisms through which the anesthetics are working. There are others that are there too, but this is the one that's obvious. The important thing about this is these patterns that I'm showing you here, this is from the OR. So you see a pattern like this for ketamine, you know the person is unconscious, right? That's the kind of key clinical take-home message from this. I had to mention this. So 2 years ago, Ezra Marcus, who's a writer for the New York Times, called me up and said, can you tell me about this? I want to talk to you about a paper of yours I read where you studied patients who got nitrous oxide. And as you know, it's become very popular again. Do not do this. This is dumb, right? And I told him, I said, I can understand why people drop dead sometimes by sniffing nitrous oxide. Because I said of the EEG patterns that I saw when we gave high-dose nitrous oxide to patients in the operating room. I'm going to show you that in a second. So this here, this is your brain on nitrous oxide. So from here to here is 1 second. These are perfect 2 Hertz oscillations. I mean, it looks like a computer drew them, right? There's no noise in it whatsoever. This is probably not a good state to put your brain in when you're by yourself, you know, because you probably will not wake up from this by yourself, all right? So what's going on here? So one of the reasons we learned about it and we wrote up this set of cases, these 19 cases, was that here's a practice of what is commonly done in our ORs. You start off with a drug like sevoflurane. And towards the end of the case, what you do is you turn on nitrous oxide, all right? And it's easier to wake patients up from nitrous oxide than it is from sevoflurane. So you're trying to get the sevoflurane off. So you turn on the nitrous oxide, you turn down the isoflurane in this case, turn it down. That sevoflurane will work just as well. And you see how the oscillations start to break up. And all of a sudden, it literally is, it's really impressive to watch. You ought to come to the OR with us and just watch it. All of a sudden, the large slow oscillations will boop, just appear like that. And that's what happened here. That's what I'm showing you right there. They just appear, and there they are, right, like that. What is so wild about this is they don't stay. They last for somewhere between 4 to somewhere 12 seconds, maybe longer in older patients. Then they go to higher frequency oscillations right here, even though your concentration of nitrous oxide is still the same. And I don't know why that occurs. And I'm probably not going to study it because this is not one of the friendliest drugs for the environment. But again, if we apply Brigham principle, the large slow oscillations are probably, one component of them probably comes from the actions, just like here, the projection from the parabrachial nucleus into the central thalamus as well as to the basal forebrain, causing this sort of chemical version of Brigham principle. And I'm often asked, like, of all the drugs that you give, is there one which closely approximates sleep? And the one that does is dexmedetomidine, right? So if you give a low dose of dexmedetomidine, you'll see spindles. So these are spectral representations of spindles. They're the spindles. See, they're like that evanescent sort of 9 to 15 Hertz oscillation. That's what you can see right here. And in fact, and you can see them over there. So they're different from the alpha oscillations that I showed you for propofol. See how these look feathery? They're like broken up. The alpha oscillation for propofol is completely continuous. So it's really obvious the difference between these. And you get a slow oscillation. So this is just like having the spindles and slow oscillation that you'd have in non-REM stage 2 sleep. And then if you gave a larger dose, you'll get just slow oscillations. And this is anatomy, which we, again, like I said, we can thank Cliff for. So one of the things that, remember, the way dexmedetomidine acts, it's an alpha-2-adrenergic agonist. So what it does is it takes out this important pathway coming from the locus ceruleus, going up here to the preoptic area, going to basal forebrain, going to cortex, going to central thalamus. So when it does that, and the more you do that, the more profound your slow oscillations get. So it mimics slow wave sleep. And in fact, there's actually, I think now, a sleeping medication which is based on dexmedetomidine, sort of trying to take advantage of the fact that it does produce better slow waves. And just 3 final points on this, 3 important what I consider clinical factoids. So if you have a young child, and Jasmine knows this better than I do, if you have a young child who's under the age of 3 months of age, they'll have just slow oscillations on their EEG. We use a GABAergic drug. Something truly magical happens at 4 months of age. They start to have the alpha oscillations, which we think is a thalamocortical oscillation occurring. But before that, you'll just see slow oscillations. Older patients, and older doesn't have to be as old as this gentleman who's 78. It can depend upon how well you've taken care of your brain. As we get older, we lose our alpha oscillations. We see just slow oscillations as the brain becomes less faithful in sort of transmitting these various oscillatory dynamics, particularly the thalamus and the cortex. That's what we're seeing empirically. And then this is another important case, overwhelming sepsis. So I put this here before the pandemic. This is a gentleman I took care of, 34 years of age, a drug addict. He had this necrotizing infection on his arm. So he had to come back to the operating room every 3 or 4 days to have his dressing changed. And so it was my turn to take him to the OR, and so I asked the nurse in the ICU, what does his brain look like? How awake is he? They said, we don't know, we haven't been using the EEG. So I was dying to get into the OR to see what his EEG was going to look like. And I thought the EEG wasn't working, because all I saw were these slow oscillations. This is a young guy who was like 34. He should have a nice, bright alpha band and slow oscillation band. And what I came to learn subsequently is that this is a very typical pattern for patients that have overwhelming sepsis or inflammation, that they have just slow oscillations. And we saw a lot of this during COVID. In fact, we have a case report, which we're just about to publish, where we have a gentleman, a young 34-year-old guy, happened to be 34 years old also, who has COVID. We show his chest x-rays clearing up as he resolves his pneumonia. We show his EEG, alpha oscillations aren't there. His alpha oscillations actually come back. I've been dying to do this, and so it makes sense, right? Inflammatory mediators basically bind to the arousal centers and actually turn them off. It's a physiologic process that helps us, think about maybe resting when we're sick. And this is work done by Mark Ott, who's a neuroscientist out at University of Washington in Seattle. So it makes sense if you have overwhelming sepsis, you would have this sort of slow oscillations. So these are important for us clinically because we see these patients all the time, depending on where our practices sit. And this is just a website from my anesthesiology colleagues so they can learn how to read the EEG. A couple other factoids. The EEG under anesthesia changes dramatically with age. There's our 30-year-old friend. Here's someone who's 57, all right? Same pattern, maybe you can see the alpha power shifted down a bit and the slow power is a little weaker, but still very obvious. Now here's a woman who's 81 years of age. You see she's lost all the gamma oscillations. They're all basically dropped dramatically. And you can barely see like the alpha oscillations and slow oscillations, right? And what's really sobering is this guy here in the middle, 56. His EEG looks like hers. His EEG looks like his. We age different physically. It makes sense our brains age differently as well. And I mean, I don't have to tell this crowd that, but what's sort of slick about it is anesthesia makes it more obvious, because what does it do? It comes in and makes the circuits oscillate. It says, how well can you oscillate? It's almost like a stress test, in one sense, like a chemical stress test, sort of hand waving a bit. It says, how well can you oscillate? Well, this guy can oscillate kind of like a young person, but his oscillations look more like hers. And you can just sort of guess what the kids look like. So there's the 3-year-old. There's a 14-year-old, all right? And it turns out that the largest amount of power, and so just one of the important factoid, several companies built these indices, these one-dimensional indices to track depth of anesthesia. Remember I said never say that term again, depth of anesthesia. And they built them on patients in this category here, like 30-year-old and 57-year-old. And the pediatric anesthesiologists use them and say, they don't work with our population. You can see why, look. This spectrum says that you have all this power, people would suggest that the person is basically, sort of wide awake. With this pattern, if you look at the pattern, you see that the person is actually quite unconscious. So that's why it's very important to understand the drug you're using, the context in which it's used, the health of the patient, the dose you're giving to really interpret the EEG pattern. But with those 4 or 5 things, you can have a very precise inference of what state the patient is in. Well, just one little small factoid. So the power turns out to be the highest between 6 to 8 years of age. I don't know why, that's just an empirical observation we've made. And after that, it sort of dies out, you know, as we get older. So those of you out there in your 20s, don't get too smug because yours is declining also, you know. You know. And one final little factoid. I mean, I don't have to make this point with this crowd, but it's very important for people to appreciate. General anesthesia is not sleep. I mean, we have a bad habit of going to patients, Mr. Jones, you're going to go to sleep for your operation, right? But if you said, excuse me, Mr. Jones, I'm going to put you in a drug-induced reversible coma. Don't worry, I can wake you up. You're not going to make many friends, all right? And your patient's going to jump off the table. So what I do is actually, what I say to them is, you know, Mr. Jones, you're going to be unconscious, don't be aware of anything that's going on, you'll be quite comfortable, you won't remember a thing that happens, you won't be moving around so the surgeons can operate, and I'll watch your heart rate, blood pressure, and make sure you're physiologically stable. I just give them the definition of anesthesia. And people are, so I mentioned this, I was outside of Boston, I'll just say it that way, a few weeks ago. And I explained this, one of the questions was, that, yeah, but up there in Boston, people don't understand that because even your cab drivers have Ph.D s. I was like, no. I think pretty much most patients can understand what I just explained to them. In other words, give them the definition of anesthesia. Don't try to use a metaphor like sleep because it really isn't sleep. And because I know, as you know, we go through the various stages of sleep, but over here under anesthesia, we bring you to a state like this, we just hold you there. If you call this a pathological state, you're actually being, relative to what the brain normally does, you're actually far more accurate in terms of describing what you're seeing. So I want to talk about multimodal general anesthesia. This is my colleague Marusa Naranjo. She's from Merida in the Yucatan Peninsula, and she's the person who introduced me to these ideas. She's like this amazing clinical anesthesiologist. She had to reduce her use of opioids in her practice because a lot of her patients were getting quite sick, and she conjectured it had to do something that she thought that there's like maybe a genetic component because the high frequency of the population in that area is of Mayan descent. So she had to alter her techniques. So we started talking about how we could deliver the anesthetics in a much more principled way, all right? So here's how we currently do it. So we have each of the various things we try to achieve: unconsciousness, anti-nociception, amnesia, and mobility. And if you look here, you see how the inhaled drugs are in every category. So that's ethers. We still use ethers: sevoflurane, isoflurane, desflurane, they're all ethers, all right? So you could just be lazy, just use one drug. But what happens is you become profoundly unconscious, but you have all the side effects: hypotension, delayed wake up, nausea, vomiting, and that sort of thing. So what we try to do is what's called balanced general anesthesia, where you'd induce with propofol, maybe run one of the sevoflurane, use a narcotic or opioid for anti-nociception. And if you're unconscious, you don't have to really worry about amnesia explicitly. And we give an anticholinergic, the muscle relaxants to relax the muscles to ensure the person is relaxed, basically. But there's no principled way of doing this, all right? What we worked out was how could you use neuroscience to help you pick your drugs in a more principled way? And so here's the idea. You need, first of all, just going to say the obvious. You need anesthesia because surgery hurts, all right? So what we should do is we should maximize anti-nociception by targeting multiple nociceptive pathways. So don't just use opioids, but something, let's say, like using opioid, ketamine, lidocaine. Maybe you're using one of the non-steroidals, all right? What that does is those drugs also decrease arousal in addition to providing anti-nociception, all right? So you have to monitor arousal. So for that, we're going to use EEG. Anti-nociception, we're going to use heart rate and blood pressure, just like we do clinically now. And you should have a multimodal strategy post-operatively. I'll just show you one case of this. So this is a woman I took care of few years back. She's 89 plus plus. So as you know, you can't say the age of someone who's over 89. HIPAA doesn't allow you to say that. Let me just say she was plus plus. All right. And she has diabetes, got a little hypertension, gonna have a laparoscopic right colectomy. She's about 5 feet, weighs about 57 kilos. So here's the combination of drugs that I use for my anti-nociception. I use 3 different drugs. So I'm getting 3 different pathways here. And she's on 30 mics per kilo per minute of propofol to keep her unconscious. Now, if you work in the ICU, this is not even a homeopathic dose of propofol. You know, you might blink once if you got this dose of propofol. It's really next to nothing. But she's profoundly unconscious at this dose. And I use rocuronium for muscle relaxation. She got some oral Tylenol and IV hydromorphone post-op. Here's her EEG. You can see she just has slow oscillations here. She's older, as we'd expect. Her vital signs are perfectly fine. And I just want to show you something here. See, this is an example of one of the indices. This is the one which is on the SedLine monitor. And you see how it's green here? When it's green, it means you're in the right range. And the right range for this monitor says you keep the number between 40 and 60. You don't have to worry about how you get it there. Just keep it between 40 and 60. That's all you need to know. You're anesthesiologist. You're not smart enough to understand anything. We'll make it simple for you, right? Just keep it between 40 and 60. And look at what happens. This thing is telling me that most of the time, it's actually yellow, right? Which means the person's outside the range, but they're appropriately unconscious. That's what the monitor is telling me. So it's telling me I should turn her anesthesia up, is what it's actually telling me. When in point of fact, she's perfectly fine on a homeopathic dose of propofol, right? So here's what's happening. The opioids, in addition to providing, as we know, anti-nociception, also decrease arousal. We could point to some of the pathways. I'll skip that for the moment. And then the same thing like with dexmedetomidine here. Again, the pathway we talked about is this pathway that Cliff has worked out. So that decreases arousal. So when propofol comes along, the amount of propofol that I need to keep them unconscious becomes much less. And I can tell you clinically what happens is the patients wake up like that, they wake up on a dime. And in fact, we were in the operating room at one time, and very often the surgeons like to start discussing the next case before the patient's out of the room for the previous case. So the patient was still in the room, lying in the bed there. She was wide awake after having come through her surgery. We start talking about the next patient and go, well, okay, the next patient has high blood pressure, diabetes, and we're going to do roughly the same sort of surgery we did here before. And the patient goes, I don't have high blood pressure and diabetes. She's like perfectly wide awake, right? So we're going to test this out on a clinical trial at the BI starting later in the spring with Bala Subramanian. We've worked out a formulation of this for cardiac surgery, actually. We're going to test it, really give it a good test in cardiac surgery, compare this multimodal approach to what's currently done for cardiac surgery. I want to tell you about 2 final things, closed loop anesthesia and reanimation. So if you knew what to watch, the computer could watch the brain better than we can and could help us dose the drugs on a second-to-second basis. And we know that from pilots, right? Once the pilot takes off, if you know you're going to fly from here to Tokyo, you turn it over to the autopilot, and the pilot takes over again once they're an hour out from Tokyo. So why not do something similar for longer operations in the OR? So this is a standard control system. Let me just take you through this. The MOU stands for marker of unconsciousness. So you need something you're going to track. I'll show you what that is in a second. So here's where the marker is. So based on where you want it to be, the controller runs the infusion pump of propofol into the monkey. And in this case, it updates every 20 seconds. All right, it changes the dose at most every 20 seconds, but there's a constant infusion, in this case of propofol. So it reads where the marker is. You take the difference between where the marker is, where the marker is supposed to be, and that runs the next duty cycle. Right? This is just textbook control. This is pulled right out of a control theory textbook. There's nothing deep here. All right. The science and the research comes in knowing what it is you want to control. All right. So here's how we figure that out. You have a constant infusion of propofol And remember, I showed you how the spike rates went down with a concentration of propofol. So you're not going to stick electrodes in someone's brain and measure their spiking activity in their cortex, but you could measure the power on the EEG. So the power in the 20 to 30 hertz band in the EEG actually mimics directly what happens with the spike rate. So we can control this and know we're controlling this. And I showed you that when this got to be very low, the animals were completely unconscious. So that's what we're going to do. So let me just show you this. So where are we with this? So we built a version of this 10 years ago, and we did it in mice, or excuse me, did it in rats. And the FDA said, well, that's cute, but that's not good enough. You have to do it in larger animals. That's why we've done this in non-human primates now. Thurl Miller at MIT. So let me just show you how this works. So first we set the marker to be at 1. And then what we're going to do is we're going to run a constant infusion, because that's what we typically do in the operating room. We run a constant infusion. And you're going to see the marker just wander all over the place. Then after about 30 or 40 minutes, we're going to let the controller take over. Let me just start this here. So it's supposed to be at 1. You can see it starting to wander all over the place. It goes up, it's going to start dropping now. The infusion rate you can see here is constant. Now the controller takes over. Now it locks it in and holds it right there at 1 where it's supposed to be. Now what we're going to do is we're going to take it to a deeper level of unconsciousness. So drop it down a bit. So it drops down. It goes right down to it within about a minute or two. The controller takes it down. Now we're going to take it to an even lighter level than we were before, above 1. And the controller moves it back up there. So now we've done this in over about 19 hours of control over 2 animals and tested this pretty thoroughly. I just want to show you something clinically, which I think is very important. This is a constant rate infusion of propofol. What happens with a constant rate infusion of propofol? We get deeper and deeper and deeper and deeper. That's what's happening to people right now in the ICU and the operating room. Look what the controller did. The controller came online and says, way too deep. It shut off for 3 minutes to let the marker get to where it needed to be, or just to reestablish control. So it illustrates very critically, I think, what's happening with patients clinically and why something like a control system would help us out dramatically, especially in the ICU, where we have patients on drug infusions for several days. And so this is some work my colleague Ken Salt has been doing for a while, turning the brain back on after anesthesia, which is something I think we should do also. So if we think about it, monitor the brain carefully using the EEG, use a control system to dose the drugs. Now, once we're done, turn the brain back on. All right, if we could do those 3 things, I think we without having any new technologies, new drugs, this alone will cause, I think, major improvements in care. So this is one of his rat volunteers who's anesthetized with propofol. He has propofol running to the tail vein. And you can see he's breathing sort of rather comfortably. And Ken has a stimulating electrode in his VTA, his ventral tegmental area. And now he's going to turn it on. He didn't turn the propofol off now, remember that. Propofol is still running. He turns it on. Look how he starts breathing like crazy, first of all. The propofol is still running. Whatever we did overcame the unconsciousness produced by the propofol. And says, Ken, I'm out of here, all right? All right? He got up and ran off, right? But is he cognitively processing? Can he actually work? So to test that, Ken did a different set of experiments. What he did was he trained the animal to perform a task. Touch a light, the correct light, turn around, get a food reward. All right, touch a light, turn around, get a food reward. So he does the same experiment. He anesthetizes the animal in the box. The animal wakes up and goes, oh, I'm in the box. I wonder if I touch that light, I'll get some food. So he starts working again. Ken doesn't turn in this case, the sevoflurane off. And then once he turns the stimulation back off, the animal goes back out. Because we could turn the brain on and off at will. That's the point we want to get to. And this is an illustration of that. So there's the animal in the box. He's anesthetizer with isoflurane. But Ken's going to turn the stimulation on now. It's not off. It's not on at the moment. Turns it on. He comes to. The isoflurane is still there. He looks for food, but there's no free lunch. He's got to work first. All right. So he hits the light. That's the correct light to hit. Turns around. So not only is he awake, but he's also doing some level of cognitive processing. And remember, he's doing this against the isoflurane. So he turns around, again, gets the food. He's going to turn around one more time. I think he gets this one wrong. And now he hits the light tells him it was wrong. All right, turns around again. So now he's going to turn around again to execute another trial. And watch what happens. Ken turns the stimulation off, and he's out. So this is suggesting that we can maybe control arousal states as much as we want to, and if we could develop finesse with this, this would really change the practice of anesthesia dramatically. But we need to do basic science research like this in order to get to that point. And what are we doing here? So Ken is actually stimulating here in the ventral tegmental area. So I mean, we think of this as a pathway, and again, you guys know this better than I do. One of the pathways for reward, but it's also important for cognition, because this is one of the pathways where we think that Ritalin is actually working. So Ken has done this with Ritalin as well. So it actually comes through the limbic system here, through the limbic system here, on up to the frontal cortex. And Ken has also done this optogenetically, isolating particularly the D1 neurons in the VTA and showing that they're sufficient by themselves to sort of turn the brain back on. So the idea of having precise targets we could hit suggests we could find precise targets. So what have I shown you? So all the anesthetics produce slow delta oscillations, different mechanisms, and sort of following Brigham principle. Each anesthetic has a different EEG signature. It changes with dose, the patient age, physiological condition, and also the and also the class of the drug. So drugs in the same class, like the drugs which work on GABAergic circuits, will have very similar EEG patterns. So these, if you can track these markers, you could generate a closed loop system. I showed you that. Multimodal anesthesia, general anesthesia, is a way to pick the choice of drugs in, I think, a much more principled way. And that's something that we're working pretty diligently on now. And reanimation, we have to turn the brain back on. You can't have someone's brain sitting there doing this for 4 hours and then think that as soon as you turn off the drugs, the brain's going to pop back and be healthy. It's just not going to do that. You got to help them out. And I think that something in this category is going to work. I didn't show you Ritalin, but Ken has some really cool experiments he's done with Ritalin. It may turn out that one of the amphetamines is better. But that's to be figured out. But we should find something in this class of drugs to turn the brain back on. And so you've seen the New Yorker cartoon that shows the New Yorker's view of the United States. This is an anesthesiologist's view of clinical neuroscience. You know, here we are in the center, and the rest of it sort of revolves around us like this. You know. But it's true. There are all these really cool, rich connections that we don't ever think about. They give us really important ideas, or they can teach us things about the brain, but we don't take advantage of them. Like, for example, if the neurosurgeon is having difficulty finding an epileptic focus, we have protocols that we use, like methylhexatol, will induce seizures, basically. At higher doses, you can actually use methylhexatol to actually treat a seizure. And you know all about ketamine being used to treat depression. It's been a model for schizophrenia, and it's a very potent analgesic. And hibernation. So this is something I just really got my head around recently myself. When the painted turtle hibernates, it becomes hypothermic. It actually ramps up its production of GABA and its sensitivity to GABA. Basically just turns itself off. And when you look at its EEG, someone has actually measured the EEG in a painted turtle. It actually is in burst depression. That's just high-dose anesthesia. And so there are all these connections between what neuroscience and anesthesia that are underexploited because we're sitting over here in pharmacology. I mean, I was telling Mike we should join your society, so we should add one more name, and anesthesiology, to the heading there. But anyway, I think this is where the future is, neuroscience for anesthesia. So thank you all.
Emery, I'm very excited about the reanimation, but if you could talk a little bit about the neuroanatomy, and how did you pick out the VTA? Did that come from drug effects, and therefore you went after the VTAs to emulate the dopamine phenomenon?
That's exactly right. In other words, we knew that that's where Ritalin probably having its effects. So we went after VTA. But we've done this in other areas too. So you could do the same thing with the PB. You could stimulate the parabrachial nucleus. You get a very similar effect. So I think
so it's not specific to dopamine. It's not specific to VTA.
You just need
any arousal area.
A good strong arousal center. And what I bet would probably be the strongest would be one of the cholinergic centers. Like if you were to let's say PPT, LDT, or something like that, simulate them, you probably have a very potent arousal center, potent wake up.
And then I noticed that you were using 20 hertz or 40 hertz to kind of quote unquote activate the region. That you turn that electrode on at 130 hertz, which we use to kind of quote unquote shut down region.
Yeah.
Could you induce anesthesia in these rodents with 130 hertz in the same spot?
We've tried some things like that. No, it doesn't work. So that's why I'm showing. This is the easy part.
Waking them up.
Is waking them up, which is great, right? Because that's one of the things, there we can have immediate sort of clinical impact. Finding the right combination of sites that you could use to sort of generate the state of anesthesia, that's our harder problem. So we're really rolling up our sleeves on that over the next 5 years to see if we can pull that off. But we figured the Ritalin idea out a long time ago, and this is something we want to get into human clinical trials by next year. It should be very feasible. That alone, I think, will change practice. Question?
Yeah, kind of a related question. You're thinking about pathways in the brainstem, like the VTA, that go cortically and around the serotonergic DCI. And pathways in the brainstem that are connected thalamus, maybe coordinating slow waves in that pathway. Do you think that how do you think about that relationship? You're looking at those rats and simulating intervention segmental areas. Do you think that they're large synchronization across the brain, or is it just one specific pathway that's being activated?
Yeah.
So it's humans which pathways really
are relevant. Yeah. No, that's a great question. So, so there's more to it. So if you look at this diagram here, this diagram just shows the VTA projecting up to cortex, right? But for this to really work, you have to have the downward projections activated also. And in fact, one of the things we saw was the animal started breathing like crazy. You've got to get the circuit going. If the circuit doesn't go, nobody's waking up from anything, basically. And so we were lucky in one of the first places we picked, VTA and using Ritalin, that, reestablished, essentially this sort of circuit phenomenon, because you can see that one of the things that occurred was the fact the animal started breathing like crazy, his brainstem came back as well, right? At the same time. So we've got nice normal anatomy there. The descending projections are working. And so as long as you have that intact, something like this should work. That's how I think about the anatomy. I should have mentioned it. You have to get the circuit going. If that doesn't happen, nobody's waking up. Jasmine?
Thank you for this talk. Very excited. Thank you for this talk. I worked with Emery a long time ago, and I always really enjoy this work. Since leaving and kind of going to UCLA, I was very interested in coma in particular.
Right.
I'm interested in hearing sort of what you think are some of the deep structures that you think will be kind of future targets, maybe aside from thalamus, and if you think that there is an anesthetic that is a close approximation, kind of like what you're talking about with dexmedetomidine and sleep, if you think there's a good one for comatose states as well that we could use to try and approximate it in a patient setting.
I mean, that's a really good question. So, so I'm kind of happy about this because it's an idea where something from anesthesiology went to neurology to be tested. So our colleague Brian Edlow over at MGH is now running a protocol in a neuro ICU where he's administering Ritalin to see if he can wake people up from coma. And he's doing his very graded doses that he's able to give the patients. And I can't say how it's going, but in other words, they haven't stopped this trial. Let me put it that way. All right. And so the idea there, but what I like about what Brian does is he just doesn't give it to everybody. He maps out the physiology. Is it likely the physiology is intact coming from the brainstem? Is it likely that the anatomy is intact coming from the brainstem? And what's the state of the cortex? So we need to sort of have kind of positive answers on all three of those. Now let's try Ritalin on this patient, see if we can wake him up. And I think that, so you have to know that, so let's say you have two pathways coming out of the brainstem, and let's say they're essential. If both of them are gone, maybe there's less of a chance of you waking someone up. But if there's one intact, you may still have a chance. So that's what I like about Brian's approach, is that he's figuring out the anatomy, figuring out the physiology before he sort of makes an intervention like that. I think that's the kind of way we'll have to think about it, because if the pathway, and that's why it's so important to do an anesthesia, because there's no reason, all the pathways should be intact. And if we can't wake you up with intact pathways, right, it's going to have a hell of a time trying to wake you up when you've got some of your pathways that have been disconnected. So that's why we should be pushing this research in the anesthesia field, first. John?
So it looks like these, the changes in the EEG are state transitions with when you start getting the anesthetic doses high enough. Do you think that's at a pharmacokinetic level that the individual cells are having that state transition, or is it like a circuit level where you turn down one component of the circuit, then everything kind of switches over?
I think it's circuits, from what I've seen, again, especially looking at the way the things appear in the way they appear in particularly the non-human primate data. So for example, before we had these data, someone would say like, oh, the brain is just being turned off, but that's not what happened. You get these highly structured oscillations. It means you're getting coordination among brain regions. I didn't talk about the alpha oscillation. The alpha oscillation we think is a highly coordinated rhythm going back and forth between thalamus and cortex, right? So that's probably not individual cells. That's cell assemblies, as Nancy Capel likes to say, that are basically working together to generate a state like that. And the same thing is probably occurring like with slow oscillations. I remember I showed you 4 or 5 different examples of how slow oscillations are produced. Those are probably not individual cells, but individual cell circuits or cell assemblies that are generating them. So I think that's what's basically going on there.
You've demonstrated that the different classes of anesthetic agents can render someone unconscious by completely different physiological means. Is there a preferred physiologic means for patient care?
Yeah. Unfortunately, at this point, no. And that's one of the reasons I like to point this out, is that the drugs go everywhere. And I think that if I could have my druthers, right, I would design something that was, did it the way the brain does when we go to sleep, except make it more profound. So when we go to sleep, just sort of hand waving for the moment, we turn off the brainstem inputs going up the cortex. So the brainstem just sort of turns off. It's like flipping the light switch. The architecture of the cortex just kind of stays intact and just sort of says, okay, I'm just not getting any inputs, I'm out. That's going to be much healthier, I think, than doing this to the cortex, having the cortex sit and do something like that. I think that's the sort of approach I'd like to create. So like right now, we've started a collaboration with 3 laboratories at MIT, each looking at a different way of trying to approximate that, to see if we can sort of just turn the brain off with 1 or 2 sites, essentially. And it's a much harder problem than waking up. The waking up problem turns out to be much easier. But getting control of a sufficient number of inhibitory networks so you can turn the brain off, that turns out to be non-trivial. And actually, that's one of the reasons why I'm interested in like the networks that Mike has been studying to really understand like how they, as you improve patients' states with depression, could we exploit some of these same networks to maybe turn the brain off in a sense? So that's why I think these sort of dialogues between us are so important, because the answer may be sitting, you know, right next to us, but we're so siloed we don't appreciate it. Question?
Yeah, so at one point you mentioned that one of the potential mechanisms of action of anesthesia is disorganized oscillations.
Mm-hmm.
I was just wondering if you've seen or looked at changes in alpha or theta phase coherence during these during anesthesia.
Yeah, so actually it turns out that pretty much most of the oscillations are highly structured, highly coupled, highly coherent. And there's a phenomenon which Patrick Purdon wrote about a few years ago called basically peak max, trough max. And it's basically a coupling between the peak of the slow wave and the maximum amplitude of the alpha oscillation. So there is something like that going on. That's very, very real. What is not real, though, is there was a device called the BIS monitor, all right? And the BIS monitor computes what's called the bispectrum. So the bispectrum is you have frequency on this axis, frequency on that axis, and it measures the coupling frequency by frequency, all right? So many people had shown shortly after this monitor came out that there's really not much coupling at all going on off frequency, not the way the BIS has been constructed. On the diagonal, you have the spectrum. So all the information you need, or 99% of the information you need, is just basically on the spectrum. Except there are some special cases where it's phase of one coupled to amplitude of the other. That is definitely there, but it's not the sort of coupling that this monitor was looking at. So that is there, and when it's there, in the peak max state, it suggests the person is profoundly unconscious. That could be used as a marker to have someone appreciate that a patient is unconscious or profoundly unconscious.
Phase amplitude coupling is or isn't there?
When it is there.
When it is there.
When it is there.
And was it between like delta and, is it specific phase amplitude coupling, delta and beta?
Well, what he's reporting is, it turns out it's there for pretty much slow and delta, and all the things sort of above, but the one which is most noticeable is alpha. It's probably there for beta also, but the one which is really apparent is like alpha.
I'm going to try to read a comment and question from someone who's online. So, great talk. Thanks, Dr. Emery. I know you briefly touched on this, but I'm curious whether you've done any recordings directly from thalamic nuclei, particularly central medial and prefrontal. And I assume that's what CM/PF means. And seen similar patterns when patients are under propofol or other anesthetics.
We have actually in the work I was talking about with Earl Miller. We actually in a few of the cases we actually put in electrodes into the central thalamus and recorded at the same time. And we could actually see the oscillatory dynamics there directly. Basically, the ones that I mentioned before, but going back to the thalamus and the cortex. So we have actually seen that, and it was good for us to see because it reinforced this idea that this alpha oscillation is something going back between thalamus and cortex. And one of the things that one of the graduate students is working out now is the layer differences between the various the cortex and how the oscillations maybe change as a function of layer. So there's a lot going on there. And it's so much so that I was just telling Mike before we started that I don't think it really matters anymore how the current anesthetics work, because we're just going to find more oscillations, there are going to be metabolic effects, and we have these endless debates about which one is more important than the other. I think we should throw that question out entirely. I think scientifically it's going to mislead us if we keep keep tracking it. We should try to build anesthesia from first principles, like the question you guys were asking about. Is there someplace you can go and generate this? That's what we need to figure out. Because if we're able to do that, that's going to have implications not only for anesthesia, it's going to have implications for some of these other areas of clinical neuroscience as well. But if we're still trapped in the pharmacology mold, it'll never happen. And not only the patients in anesthesia lose out, the patients in other fields of clinical neuroscience lose out as well.
I've got a question for you. I love that on your clinical neuroscience map, according to an anesthesiologist, that hypnosis and meditation make the map. There you go. And especially given that we have the luxury of a career's worth of reflections from you here, I'd be really fascinated for any speculations you'd be willing to offer about why states like hypnosis meditation or therapeutic ketamine tend to result in insight-like experiences.
You're asking the wrong person about this now. People ask me, they say, oh, I love hearing about your work on consciousness. And I go, I work on unconsciousness. Right, that's what I do. It's a great question, but I guess what I start to appreciate is that, you know, when that drop between the sort of these 5 microvolt oscillations down to the slow oscillations, there's a lot of space in between there. And so you're limited by how well you can titrate the drugs and what sort of luck you have in certain cases. We were talking about this in the reception. I have a colleague, or a former colleague of mine, who was quite good at doing hypnosis on patients, and she dramatically reduced the amount of propofol. She had to give them to have like they're having their AICDs checked, basically. So these states exist. They work. I mean, they exist. What we don't have is a way to sort of get to them reliably. And again, if we're still doing very crude things like this, we'll never figure that out. But my colleague Bala Subramanian over at the BI has a meditation routine that he takes some patients through. And it's a 12-minute meditation routine that he can teach patients before the surgery. As a consequence, he's also able to reduce the amount of anesthesia he gives them when he does that. So what I think is very clear is that anesthesia is still very crude. It's amazingly crude. So we just get lucky when we get to little snapshots, little windows into these brain states. Another way to get better windows into them is to try to put some of the subtlety in place that I've been talking about. You probably saw this paper from Carl Dijsselhoff back in 2020 about the guy who was given ketamine. They were looking at his retrosplenial area, and he had these oscillations there that were very similar to the ones they saw in rats. Just had to be very lucky to sort of see that. And it was associated with his sort of ketamine hallucinations, basically. So we haven't even begun to scratch the surface of those insights because we're approaching with such crude tools. We just have to get lucky like Carl did in this particular case. But if we can make the tools more refined, I think we can get at them.
Thank you.
Mm-hmm.
So I spent this whole time trying to think about this somewhat counterintuitive finding that you can, turn on an electrode and wake the rat up or wake the monkey up.
Mm-hmm.
You can't turn on an electrode and put him to sleep or anesthetize him or whatever the terminology is.
It's very easy to say sleep, isn't it?
And it occurred to me that the normal state is the patient awake.
Right.
And you're inducing a pathological oscillation with your anesthetic. And so it's actually very analogous to what we're doing in Parkinson's disease, where we've got a pathological oscillation. We can use a DBS electrode to break that pathological oscillation and restore them back towards a normal state.
Right.
And so I guess you could turn on the electrode and break the abnormal oscillation induced by anesthesia, but you can't turn on the electrode and create an abnormal oscillation that would induce unconsciousness. Is that the right way to be thinking about this? Is that analogy apt?
I think up to a certain point, what I would like to do, on my wish list, right, is I want to control a brain circuit. naturally, let me be very specific. Suppose, so the periaqueductal gray sends descending projections down which modulate sort of nociception, right? If I could control that, maybe what I could do is when there's someone insensate. It's a natural network. If I could get control enough, maybe I could do that. The TRN is basically, it's a reticular thalamus, means it's a net around the thalamus. So if I could control enough of that net, again, it naturally sits there and inhibits, could actually make someone unconscious. That's the way I think about it. In other words, there are these natural inhibitory circuits. Can we control them enough? And it's a harder problem than sort of just waking someone up. As I said, we had the good fortune that all the circuits were intact, and once you sort of activated the right point, everything sort of came to. But this is a much more, for this to work, it has to be much more precisely done.
Maybe I should ask my question more open-ended. Why is it easier to wake them up than it is to put them to sleep? Or anesthetize them?
See how easy it is? See? Because I think that I think is what I was saying earlier, I think the normal anatomy is working. In other words, once you drive the VTA activates cortex. The descending projections come back down to activate brainstem. Now you've got the whole autonomic nervous system activated. So now you actually get more arousal. I think you start that loop when you apply that. But what has to happen is if you're going to take someone out, you have to be sure you took out enough. And how do you know that there's enough? And what we're doing in the case of waking up, we're taking advantage of the fact that the anatomy is basically intact. And that's why it may not necessarily work in someone who's in a coma, basically, because there could be pathways that are broken. That's why Brian does a good job of sort of checking to see what's intact before he starts applying this, administering Ritalin to the patient. But of course, if you have some thoughts about this, which you're willing to share, I'd love to hear them. Jasmine?
In that same vein, what are your thoughts on, what are your thoughts on maybe what the extent is that we can do with non-invasive methods like temporal interference with, low-intensity focused ultrasound?
Right.
How far can we actually go with those to try and neuromodulate the system to get into these abnormal states, maybe as an adjunct to anesthesia,
right.
Or as a potential replacement in the future? I mean, I know that there's a lot of physical barriers, the skull, the depth,
that's a great question. So we actually have data on both of those. So we've done, remember Ed Boyden came with this technique of temporal, this sort of interferometry, where, you could, if you want to generate a 2 hertz oscillation, you put in a 200 hertz oscillation and a 202 hertz oscillation. You get them to interfere at the right place, and you get a slow oscillation there. So we tried that. It didn't work. All right. And we tried a number of different variations on it. Targeting directly the thalamus to actually see if we could get it. Because again, a central way station, right, central hub, it basically didn't work for us. Back in the 60s, there was electrical anesthesia. And when you read those accounts, there's a paper in Science, I think 1969, where they actually, essentially they said they have to give the muscle relaxant first before they apply the electricity. Like, okay, this sounds Frankensteinian, what they were doing. We've tried, the one thing which we have had success with is we've given, and this should be out in a few weeks, if not a month or so. We did a study with our colleagues at WashU where we gave them dexmedetomidine and sedation. So what's nice about dexmedetomidine is you can see the nice, beautiful slow waves. So when you give them the input in phase with the slow wave, you can make them go deeper. If you give it anti-phase, you wake them up. The suggestion something like this could work. So those are the 2 bits of real data that we have from our group that sort of supports what you're suggesting. But we tried for several years with the interferometry, and it didn't pan. See, in the paper which Ed Boyden published on this, what they did was they just stimulated a motor cortex and showed you got some movement of an arm. But now we're asking a much more precise question, and it just hasn't worked as well.
I was trying to link your work on the closed-loop anesthesia and the VTA stimulation. So I was wondering where you record to induce a closed-loop anesthesia. And based on that, do you think in the future we can have non-invasive stimulation to wake up patients from anesthesia after surgery, for instance? And if so, would it be dangerous to do it that fastly compared to minutes or hours after recovery?
No, I think that I don't think we'll do it with stimulation. I think there are enough drug candidates around right now just to do it with drugs. And we're going to test out several of those drugs probably, and like I was saying before, probably, so when I first had this idea about trying it, we were in the operating room, and I had a guy who was slow to wake up. And so in the anesthesia literature, it says that physostigmine is the drug to give, right? So I went to the pharmacy, got some physostigmine, and it has effects. It has peripheral cholinergic effects, and the nurses hate you afterwards. So that did not work. And then we tried caffeine, basically no effect. Then we said, why don't we try some Ritalin? Then we realized IV Ritalin doesn't exist. So we had to make it. So that pushed us into doing a clinical trial, basically with IV Ritalin. PO Ritalin existed, but not IV Ritalin. I think the wake-up problem is really solvable. I think if I were just given the resources that I needed, we could have something out there in the next 2 years or so without too much trouble. I think it's very, very doable. And the harder problem is really creating the total anesthetic state. So that's why stating those 4 categories is really important, because you have to have muscle relaxation, you got to be unconscious, you have to have amnesia, and physiologic stability. That's hard. That's really, really hard, and control of nociception. But I think the wakeup's not going to be that hard, and I think we can probably do it with drugs.
There's another online question. I hope you can hear me.
I can. Mm-hmm.
There's some evidence that stimulation of basal forebrain cholinergic neurons causes cortical desynchronization. I was wondering if you could provide your thoughts on the role of the cholinergic basal forebrain / basal forebrain in general, in consciousness, and particularly as a neuromodulatory target.
I mean, I think that's a great question. I think it's an empirical question. In other words, the answer, what I should say is, the answer has to be determined empirically. On the surface of it, it seems like a great site to stimulate to wake someone up because it's a very strong cholinergic circuit. Just like so is LDT, so is PPT. And I think it's worth putting on the list and basically trying to see what you get. Then you have to ask the question, how are you going to get there? The one thing about Ritalin is Ritalin somehow gets to the ventral tegmental area, that circuit, so it helps us out. So even once we show that these ideas may work to wake someone up, by sticking, and that's important, don't misunderstand me. I think that's what's missing. We don't have enough basic science to even know where to go. Maybe we can come up with clever ways of getting to these places, whether it's with, ultrasound or something, to disrupt the blood-brain barrier or what have you. We can try some of these things out. But that's, we haven't done the empirical work on the basal forebrain to really be able to say, this is really my answer at the moment. But if you're making a list of places, it's certainly one place you got to check out and try and see what happens. And often you're surprised. You get just I mean, like you were mentioning deep brain stimulation. Who would have thought you go below the subthalamic area and stimulate a higher frequency and things are inhibited? Do we still know? Are we still clear on why that works?
Working on it.
Okay, all right, right.
I have my own question now.
Okay.
Which is, I'm just reflecting on what you've been saying about how anesthesiology is stuck with kind of psychopharm or with pharmacology as opposed to neuroscience.
Right.
And as a psychiatrist, there's something similar in terms of psychiatry.
Oh yeah, we're battling for last place. Yeah.
I'm sorry?
We're battling for last place in the space.
Yeah, definitely.
Right.
No, we're definitely in last place.
Mm-hmm. I didn't want to say it that way, but.
So, but in terms of, we're stuck with our past, right? And but the brain is what we're all about.
Exactly.
So I'm just wondering about your thoughts about how to move these various fields that are stuck in the past into the world of the brain. I mean, I've been very interested in this question, and you obviously have been too. So.
Well, Tom Insel before he left NIMH.
Yeah.
I mean, this was the big thing he was trying to push. Really trying to put mechanistic, replace the DSM whatever we're at now with neurophysiologic mechanisms for our neuropsychiatric disorders. And I think that one of the places where we might be able to get some insight, and we take what we can get for the moment, right? One of the places where we might be able to get insight is with depression. Because, I mean, everybody knows that ketamine can be used to treat certain types of chronic depression. It turns out that so can a lot of the other anesthetics also. There's evidence suggesting that. So that to me now becomes a mechanistic question. Why? Right? So take advantage of that, and say, okay, why is it that maybe propofol could help you? And one of the good things is there's some studies which have been published which show that propofol is just as effective as ECT. And I'm sure you know that one of the drawbacks of ECT is short-term memory loss. It sucks. You have to decide, do I want to feel better, or do I want to remember? But if propofol is just as effective, 15 minutes of propofol as opposed to, 5 minutes of ECT, and you can wake up. And I can tell you, when people wake up from propofol, they feel good. They tell you that. They just gotten propofol. They go, wow, what did you give me? Can I come back next week for some more? So I think we should seek out those sort of opportunities and exploit them. I think that's basically the first step. But I think also, I mean, this is going to sound very old school, but a lot of the insights that I got from thinking about anesthetics and started drawing the circuits came from my just doing neuro exams on my patients as they were going out and coming back. Actually, the best place to do the neuro exam is in the operating room, a coma exam, because it's not going to be there, then it's going to come back. I mean, you could be on the neuro service for months and not see someone's neuro exam change. But in terms of teaching it to the medical students, it's the best place to do it. So, I mean, I was using my clinical insights to start to understand, how these things were working, and also just drawing from the allegories in neurology, like these strokes, these brainstem strokes, which show flaccid paralysis, essentially. You can actually see that with induction of anesthesia, right? Because the propofol has to go through the basilar artery, and it takes out the brainstem. When you watch, you can hold a person's arm like this. You'll feel it go like that. And so I think there's going to be a lot of stuff done with AI, but we can't miss the opportunity to continue to really look and pay attention to our patients and what they're telling us. And I think there's a move away from that the more we start talking about AI approaches. If we use AI should help augment our senses, not replace what we're doing and just turn it over to a database. because ChatGPT will not figure this out. I'll say that to ChatGPT too.
I guess one more, one more question.
Is the brain comfortable with oscillatory or repetitive stimulus?
I'm sorry, say that again?
Is the brain comfortable with this repetitive types of stimulus?
I'm sorry, what type of stimulus?
Like the repetitive stimulus of that electrodes that we use. Wake up.
Yeah, I think so. Remember, there's no...
Or can we like electrocute him like for a like short period of time, but for a long, like without any breaks?
So that's what I was saying before. That's been tried, and it got a paper in Science, but we don't use that practice because it's very, very crude. It's almost like giving someone ECT without. In other words, you have to anesthetize them first before you actually anesthetize them. That gets to be sort of circular. I think that we just have to do the hard work of learning the neuroanatomy and neurophysiology better and how to control it. And once you're able to do that, I think we're going to have some answers for anesthesia. I also think that we're going to be able to help you guys out too, and you guys can help us. We can use the information you're collecting. Right now, we can't even take advantage of it because we don't have a framework to use it. But I think that's why this is so important.
I guess one more round of applause for Dr. Emery.